we're good. Okay, thanks.
Sign-ins and
Yeah. I think we're good. I had like 30 or 27 people.
Amelia, it seems people are a little slower than usual to come, so we'll just give them a couple of minutes.
Okay.
all right. darling. How are you?
Hey, I'm great. How are you doing?
Very good.
Good to see you. How you doing?
Absolutely.
Things going well?
Things are going well. Have you heard anything?
About? Oh no,
No?
no, not yet. I'm not sure.
What's wrong, Jenna?
I'm not sure when we're supposed to find out actually.
We can, or we can move that way. Probably before. I don't think we're going to hear anything before September.
September.
Yeah.
Yeah.
Because they
I
say
got the
they
handout.
have like extra applicants.
Oh, okay. That's fun.
Yeah. So,
Okay, how's it going?
Good. I'm Tom. Familiar.
I'm Michael Goodman.
he is working on the prevention.
Oh, great.
HIV prevention.
Wonderful.
Yeah.
Doing prep for him.
I'm doing testing, doing prep.
Outreach. Your prevention.
Wonderful. Good. Good. Thanks for coming.
I think we're going to sit right here.
Are you going to tell me where we're going to sit?
Oh, no. I think we are going to sit. You can sit anywhere you want. I'm good.
All right.
Oh, really? Well, too bad I kind of decided.
Clearly, yeah.
Yeah, I'm going to say hello to you. Hello, Jack. How are you doing, darling? Excellent. Excellent. I'm good. Hey. Doing good.
Am I gonna see you tomorrow?
Yes. How was your grandchild?
You're gonna need mine. And then when Jenna gets here, we can pass on.
Teenager.
Yeah,
It's her first car, so.
Oh, yeah.
How are you doing today?
I'm good.
Do you remember what the process was to get a pass for the holiday?
We need an application.
Jenna's trying to find a way in.
They're going.
Yeah, she texted or called me. Is what I'd want to say.
You know, like we should.
She initially wanted to go first, and so she didn't know if she wanted to delay anything, so.
I think this is not gonna work.
Okay.
Can we just do this one?
Oh, of course.
Oh, so that's hers actually, huh?
Yeah.
So you need to get yours up.
There'll be a timer for me.
You want me to give you like some minutes? Like
Yeah.
5 minutes?
Mm-hmm.
Okay.
Mm-hmm. And I can just wait. I see what you're saying. They are coming in slowly.
Yeah, it's hard to know like how many people are coming in, and we have people. The issue is we have people across correctional managed care, and so if they're like piping in for their lunch or whatever, and they're like, are they going to go or not going to go? So there's a balance between people who are piped in and people who are in person. So I guess we'll just go and get started if you're fine.
Okay.
And then like a couple minutes.
So I just this.
Yeah, this one.
That one.
Yeah.
Okay.
Okay.
Okay, so welcome to everyone to this edition of Lunch and Learn. Today we're excited. We have Amelia
Murphy.
Murphy, thank you, and Neasbitt on the way, giving presentations. Both of these women are accomplished educators of providers and patients alike in the area of HIV and substance use and stigma. So without further ado, thank you very much for being here.
Thank you. Thank you very much. Hi, everybody. My name is Amelia Murphy, and I have been in the behavioral health industry for 15 years. 9 of those years, I have been directing recovery support services, and I'll get more into that later on in the presentation. So I'm going to ask for just a little participation from you guys. So when I say paralyzed, you're going to say stigma. So I'll just kind of allude to that. Paralyzed, and we say, okay, very good, thank you. Because I want to demonstrate how it has impacted the communities of HIV, substance use, and mental health. Also, I'm going to offer you the idea of the Recovery Ready framework that has proven to be an awesome service for these three areas. And overall, the solution of how the federal government, also the public health professionals, and community-based and healthcare organizations are the game changers. So, are you ready? Yes. Let's go. So I wanted to demonstrate a little bit about the awareness. And I thought if it's important to this culture, let's see how important it is. How do they take it serious? What is the impact of that? So I decided to look it up, and I found some interesting results. As you can see, that the black culture is totally aware, 66%, and also for the people they know, which is a little under 50%. And I also wanted to demonstrate a little bit why. So to talk a little bit about this culture, I wanted to know some things. And so I found some interesting outcomes of this. And so why was the struggle for equality? Why? Why? And what I found was democracy. So we're increasing democracy today. Why was the reason to reevaluate their identity? And I found that indigenous people have human, social, and economic rights. So why was the power of language so important? From the labels that they used, from color to Negro to African American to black to Afro-American, and now people of color. Why? Because of the empowerment of this race. I want to say that I learned a lot from an author by the name of Mark Sanders, who wrote a book about your right to vote. I got a lot of facts from there. I'd like to offer you that. And also, he was the author of a couple more books, and he's one of my favorite authors. He's an African-American author who's slipping through the cracks. And The Reflection of Soul. These two books pretty much put things on paramount for me about this culture. Also, there's another author that I'm truly in love with. His name is William White. And he is a part of the recovery movement that gave us valuable information to move forward. And he has a lot of books. One of my favorites is Pathways from Addiction to Recovery. So as I looked through this issue of HIV, I said, so let's talk about advocacy. What is CDC doing? And what is PrEP doing nowadays? So how many of you are aware of PrEP? Okay. So on advocacy, I saw that the legislators are doing amazing, and I'll get more into that because of CDC since 2015 and what they've done. But also, how can we promote advocacy on a scale of local governments, state governments, and national governments? Does it have to always become an epidemic? Probably not. It depends. So thank God for our research companies. Yay! So PrEP was introduced in 2012. And I saw that when it was on the market, it really didn't get a lot of awareness until 2014. So I found that why was the delay? Well, anytime anything hits the market, it's going to take a little time. Toothpaste is not that bad. So after 2000, and so they hit the market at 2014, guess who came after them? It was CDC. CDC came, and they had 3 awards that they offered. And then the results were so profound for this culture of people that in 2017, they offered $11 million for each year of 5 years. And that included the community-based organizations. I got real excited. So I wanted to know the details. How did that work? Well, it worked so well that in 2019, they're doing $11 million. $400 million. So they went from 3 awards to $11 million to $400 million. to provide prevention and care across the United States. This culture is still leading in HIV diagnosis. They are still leading. I did, and through my research, I was trying to figure out, well, why they're excelling. They have 55% increase. They're stabilizing on the medication PrEP. Okay, so they have complete awareness. So tell me, what is actually going on? Why are they still leading as a race of people? And so it got me to an understanding that when individuals have HIV, and I have to admit I did do an interview with a subject matter person, and they said to me, as much as we want to tell you, as a Black African American, that the stigma has been reduced, it hasn't. As much as we want to tell you that, what we have done, and I'll just put it very plainly, we want to have sex. So if we take PrEP and we communicate that to others, then what will your choice be? To not have sex and be ignorant, or to take the medication and inform everybody? But the everybody that they did, quote unquote, was those that they know. So we still need their support out into the communities to help. So that led me into this area where these factors are so significant. Homelessness, we're going to get into the percentage rates of that. Violence, racial discrimination, poverty, and the lack of health care coverage. So just to kind of talk a little bit about one thing is, it was an eyebrow raiser for me, was I found that 40% of gay and bisexual men through the age of 25 and 34 years old had increased by 40%. So I wanted to know, where do these areas affect them? So according to the Health and Human Service Office of Minority Health, which has a wealth of information, I wanted to know the key areas here. And so major depression. I'm going to give you a story that I had an interview with someone, and they told me we had a real talk, and they told me the real truth. Attention deficit hyperactivity disorder, and that would be me. Suicide among young Black and African Americans, which is mostly men, and PTSD, of course. And some of these individuals that I studied had a high ratio of crime in their families, in their homes, in their neighborhoods. So basically, they were looking at, how do you have a success of a life when your environment is under attack? So let's look at homelessness. 40% with the Black African American. Also, let's take a look at the mental health conditions. So we just saw that depression was number one, anxiety and so forth, but also the children. It was alarming to me on how they were affected as a subculture in their families. So I looked at, what are the influences? And I was very interested to know that only 41% of this culture, people of color, actually pursue to go into a clinic, go see a therapist, psychologist for the mental health conditions. And I was understanding that very clearly. But overall, I said, why? Why? Paralyzed? Yes. Paralyzed? Yes. So, these are the factors. My employment today, and has been for 15 years, is working with indigent and homeless women and women and children with an organization that provide substance use treatment, residential and outpatient, housing, family, and just a few years ago we added recovery support services. So I know all about this culture. And when we asked about the low income and what could we do to support that, look at the rate, it's 27%, and the lack of insurance. I really wanted to know, as a person in recovery, since July 13, 1990, that's 28 years, I myself was raised in an area where there was low income. And I saw what was in the environment. And I applaud my parents for doing the best that they could with a wild child. I was adopted, and my mother was an alcoholic, died at 26 from alcohol, and my dad was a drug addict, and he got clean. I think he's 84 now, and he got clean when he was 72. So to know that this is important and to talk to another peer is paramount. So let's look at the attitudes. What is the attitude? Okay? So I said, okay, let's take a look at this. This is very, very important. And what I saw was they have fear. Fear. Huge fear. This is real. This is real. Fear of stimulant medications that would cause addiction. Some of them take medications because it can give them some type of a high, if you will, quote unquote. They do this because they're escaping. They're trying to manage all the traumatic events that have not been addressed, or that they don't know how to cope when they're out into public arenas. Also, this is the one that really, really, I guess you would say, that has my energy going, is not understanding the natural biological, if I would say mental illness. They do not want to understand that. And I'm going to give you a story of why. They will go, and if a counselor or if a therapist or someone says while they're in a service, say you need to go and get your medications, you need to take your medications, you need to stabilize on your medications, that will work for just a very short period of time. If they're continuing in the service, they will sustain that. However, how could we manage that when they're out of the service? What's the motivating factor? So I also wanted to know how many Black and African American professionals, healthcare professionals, was available in some of these areas. And so what I came back with from my research is that we need more. We must have more on this culture to help them. So, getting into something that I thought was very interesting here is the rates of drug use and sales by race. So there you go. We have two races, the Black and the white race, and so the use of drugs was a little higher than the Black race, but both of them were pretty much even on the sales. So when we look at the rates, again, for drug-related criminal justice measures by race, we see that the Black race is much higher. Also, drug-related incarceration is much higher, and drug relation on a federal level incarceration is much higher. So I got real excited right there, and I said, okay, so this is why I'm in this work, and this is what I want to know. I absolutely believe that had social economic conditions been different, we might not have such high statistics. Again, I'm looking at poverty. I'm looking at all these things that have a great impact in the Black and African community. And I think it's very important to identify these areas that you see here. Poverty, and I can't stress that enough, illiteracy, limited job opportunities, poor education, high availability to drugs and stresses. I found that, why are they having so many liquor stores in their environment? Why do they have all these trashy restaurants with fast foods in their environment, in their actual neighborhoods, that create heart disease, that create diabetes, cancer, and like the top 5? Why? So, in addition to, I don't want to miss this, absolutely don't want to miss this, is about the violence. So, as I alluded to earlier, the children have been exposed to violence in the home, possibly due to many, many factors that I just addressed. But I do want to say this. The women, the Black African women who have experienced violence, and I am one who experienced domestic violence. Today, I am a survivor. I escaped with my 3 children, and I promote all of those resources in the community for those that don't want to talk about it. They feel as though it's not going to help me because I keep going back to this guy. So we look at assessments, the healthcare professional, all of the folks that are involved. We look at the core issues, and most of it comes to, it's a sexual addiction. That's chained to that. If they can have all this good sex, somehow they're blindsided about all the domestic violence that take place in the home. And I look at that and say, I was one that went back to my husband on a few occasions. And my children would just drip when they see all of that happening right before their very eyes. And I would escape. But why was I going back when I know that this is going to happen again? Why? I had an idea that I never wanted to live alone, so I'd go back in this beautiful house and drive this beautiful car and go back to the nightmare again and somehow survive it. And my life was at stake. It got to the point where I was carrying my last baby, almost 9 months pregnant, the day that my father we had his funeral that very day, and it was all about a 20-pound bag of rice that he had to go pick up. And I was very angry because I thought this was about my dad. I'm a daddy's girl, so you need to take me to my dad's funeral, and the family is there. And he took his gun, and I was standing in the kitchen, and the cabinet was right there, and he just shot right there. So I managed to get through the funeral. I managed to have another baby. And somehow I lived with this trauma until this kid was about 3 years old, the baby. And I found an escape. Thank God I found an escape. I went to an organization in Houston, and I think I know I was ready, because I haven't been back since. I got a divorce. I know the signs. I know all of that when someone even looks as though, for all that I was taught, all the education was well worth it, I run. Run, Forrest, run. And I share that story with many, many women. So we go into, make sure that I cross this out, because I want to say that there's a black director. There's a black director who has a movie that's called Blink. And I love it. And it was very powerful for me to have that experience. So we share that as well. So solution 1, address each participant as an individual. How many times have we said next? How many times have we said okay, and our mind is somewhere else? We found the value of actually getting a person as a real person, sitting here with real issues, time. They're human beings. Not that they're African American or black human beings or people of color. They're human beings. So how many of us actually take the time to get to know all of this moving forward? How many of us use and really use the impact of motivational interviewing? I'll get whatever needs to get done through MI when I'm working with the individuals. Also, I want to say that I just want to do a celebration for Recovery Support Services because because for those of us that know the impact of Recovery Support Services is my energy. It's because we get things done. It's because we come from a peer-to-peer model. And we know how to help them. We are the subject matter experts. We are the experts. And not only that for substance use, but we have mental health experts as well on a peer-to-peer model. So we find that if we do that, then we're helping build a community with the stakeholders, because now we're a part of the stakeholders, because we have been under research for the past, I think it's 3.5 to 4 years now. We saved this state over $2 million. The governor loves us. You know why? Because we get it done. So I wanted to share this with you. When you see data, statistics, think of daughter, think of son, think of neighbor, and think of friend. They told me, Amelia, if you want to talk on the sidelines and use the ignorance of that, then you will stay there possibly if you don't get into the action of it. And I said, how do you do that? Be passionate about it. Get in the middle of it. If you want to do something about it, get out to the courthouse or wherever you are and get involved. Get involved. Don't be afraid of legislators. Don't be afraid of that. That's where the real power is. So I wanted to share with you today how important. There's 3 areas that I alluded to first. And it was the government. But before the government became something that I really want to acknowledge, there had to be a need. We talked about that earlier. So what is the federal government doing? I'll tell you, collecting data to monitor and track health and conditions that affect health. They are supporting partnerships with scientific researchers and community members. So this is my favorite. They are they have a national initiative that's called Million Hearts that's addressing heart disease, stroke, and cardiovascular diseases. Also, they are supporting creating healthy food environments. That's my second favorite. So they're also putting big money to the table, as I mentioned earlier, $400 million across the table. So coming from 3 awards to $15 million to $400 million is saying a lot for them. Public health professionals, what can happen there? Use your proven programs to reduce disparities and barriers. You need to work with others, such as faith organization, education, transportation, to improve economic conditions. Also, we advise to utilize the services already there to link more people to doctors and nurses and community health centers. I went to the hospital because of a hypertension, and this hospital was great, but then I had to go back and get my medical records, and I walked 25 feet, and guess what I saw? It was a community organization. They had food out. They had people out. I wanted to be a part of that. And so guess what? I paid the bill big time. What was the motivating factor? Because they were helping the community. I don't usually pay a medical bill like that. I said, what can I do on payments? Let me put you in somewhere, But I paid them off because I appreciate the work that they were doing in the community. Also, I want to say, and I'll close with this, healthcare providers, what can they do? They can work with communities and healthcare professional organizations to eliminate cultural barriers, and that's one of my missions. To connect patients with community resources, they also need to collaborate with primary care physicians, and I think to create a comprehensive and coordinated approach to patient care. I really believe that should be taking place, and most importantly, promoting trust so that the individuals or their patients can ask more questions. So when I say paralyze, we got to say it loud. Paralyze. Stigma. And are you the one that can help us remove the stigma? Are you a part of the game changers? Or are you the game changers? Thank you.
Thank you, Ms. Amelia, for that informative and passionate talk about stigma. The next presenter we have today is Ms. Jenna Neasbitt. She has over 2 decades of professional experience working in a variety of capacities with HIV, mental health, substance use. Thank you for being here.
Yeah.
Let me put this on the
Okay.
thing. Oh, let me see.
Yes, please. While he's getting us set up, I wanted to thank Amelia for her flexibility in going first. I had asked if I could go first, and when I could not locate where I was supposed to park or find the building I was supposed to be in, I texted Amelia, and she very quickly said, "Yes, I got you. I will go first, boo." And I was like, oh, thank God. I'm going to be honest with you. I am nothing if not transparent. I'm a little nervous about this presentation today, mostly because, like Amelia, I'm involved in many projects across the state of Texas and the nation, and so it feels like I'm always running from one project to the next, and when I'll send off a PowerPoint deck and then be like, okay, on to the next thing. So I literally just rehearsed this in the hotel room with my mom, who was sweet enough to accompany me today. Everybody, this is my mom. As stated, my name is Jenna Neasbitt. I'm a woman in long-term recovery, and what that means for me is I have not used any alcohol since June 29, 2012, and I have not used any illicit substances since September 1998, and I couldn't tell you the date, okay, because I was still drinking. And what that's allowed for me to do is become a present daughter, a dedicated wife, and a loving mom, and really connect with people in a way that I really wasn't able to when I was still drinking and using other substances. So I'm very pleased to be here with you all and to talk a little bit about stigma. There's the long biography, tells you a little bit about all the things I'm involved with as I run around from town to town and state to state. And I'm very privileged to focus all of the work I do on recovery support development, recovery housing, and the opioid response across the nation. And with the information that we put together today, I took it from a publicly available PCSS, SAMHSA-funded resource and have adapted it with some of the other material I have access to. All of the references are going to be included at the end of the slide deck. But because I'm giving you kind of a high-level overview to accommodate a quick 30-minute discussion, not everything that goes with those references have been included in the deck. And if you're curious about this original content that I adapted it from, all you have to do is Google PCSS MAT and Sarah Wakeman or Dr. Wakeman, and you will find it. But it really just kind of served as a template because, quite honestly, without a very concrete template, I will stand up here for hours and talk to you guys. So I really just wanted to make sure that I was able to provide to you a more condensed version of the types of things I provide to TA requesters, technical assistance requesters, throughout the nation and in Texas. So obviously you see the objectives that are listed here. And, you know, Amelia did a great job talking a little bit about stigma and the African American population and what people of color face. And there will be a little bit of an overlap with that as well for me. But we're going to start with a few basics. You will hear people say SUD and addiction often interdependently or to describe the same condition. And there's a difference because SUD is a spectrum of behaviors and consequences, whereas addiction is a chronic medical disorder. And as you can see, this was codified by AMA in 1990. And what's weird is it's largely accepted in our country, maybe not in other countries, but in our country as a chronic medical condition. However, we continue to respond to it and treat it like a moral failure. Substance use historically has been subjected to some demoralizing paradigms, and I'm going to give you a little bit about that. The war on drugs was actually initiated early in the 20th century with Harry Anslinger, who was the first commissioner of the Federal Bureau of Narcotics, and continued on with the was actually doubled down with the Harrison Anti-Narcotic Legislation Act of 1914, which made it illegal for doctors to dispense medications for people who were suffering from addiction. It made it illegal to treat addicts, and it also made it illegal to be an addict in America. And so that was a pretty damaging start. This legacy was continued on with the Nixon administration, where we saw a dramatic increase of federal drug control agencies. It continued on through the Reagan administration. Does anybody remember the phrase from the Reagan administration? Just say no. Nancy thought she was doing a good thing. It's really hard to fault that sweet little lady for doing what she thought was right? And back then we thought, yes, that's all you do is just say no. But we've now learned that depending on where you come from and the traumas you've experienced and how many adverse childhood experiences you've had and your access to health insurance and just so many things, 60% epigenetics and 40% environment, that is what kind of dictates whether you can actually say no or not. And if you say no this time, can you say no the next time? And this continued on. I could go on a tangent about that. This continued on with the Anti-Drug Abuse Act that was also passed under the Reagan administration that imposed mandatory minimums. And then we saw the Bush era usher in a staggering number of militarized drug enforcement entities. And then with the Clinton administration, he rejected the suggestion that we end the federal ban on funding for syringe excess programs, which is, as you may know, is a public health effort to mitigate the spread of contagious disease, and obviously to mitigate opioid and overdose mortality. What President Clinton also did, so you can see I'm taking a bipartisan stance here at what everybody has not done right over the past couple of decades in our country. He also rejected the notion from the U.S. Sentencing Commission recommending to eliminate the disparity between crack and powder cocaine sentences. I don't know if you guys know that, but it's essentially the same drug. And with crack cocaine, those sentences are often 100 times harsher than cocaine sentences. And the crack punishment standards imprisoned more people of colors than white over the course of from the time this passed with Clinton until the Obama administration reduced the disproportionate sentencing from 100 to 1 down to 18 to 1. So we're still not quite level, even though it's the same substance. And the reason why, Dr. Carl Hart will tell you, look him up, Dr. Carl Hart, Columbia University, he'll tell you that it's very much a racial situation, that blacks can afford crack and whites can afford cocaine. So I know that's a pretty polarizing sentiment, and I'm bringing that to you just to kind of frame what's really happened. Meanwhile, we have the AIDS epidemic really starting to burgeon in the Reagan area. It was known as the gay plague back then. I was little when this started to all kind of come on the news. I was born in 72, so I would have been probably 4th or 5th grade when we started hearing more about AIDS and the gay plague. But this narrative was, at the time when it was starting to really unfurl, was presented as a joke by the White House press secretary at that time. And as many of you know, nothing was done federally to address HIV until 1990. So we have kind of a confluence of two highly stigmatized conditions happening at once. There's a great overlap between HIV and SUD because of the needle sharing connection between the two as far as co-occurring expressions occur. So we have more biases happening mostly due to the rapid nature of the increasing intravenous drug use. Have you guys heard of, I think it's Las Vegas, Indiana? Nobody heard? There was an HIV epidemic in Las Vegas, Indiana. This is where Jerome Adams, that's our current Surgeon General, this is where he came from. And when he was in the state of Indiana, he convinced Mike Pence to fund safe access for syringes and needle exchanges, and then they were able to watch the HIV rates then start to curb a little bit. But prior to instituting the needle exchanges, they had a full-blown epidemic there, due to the opioid epidemic as well, due to the opioid crisis. What's so interesting is we know that there is a public health initiative to address needle sharing and intravenous drug use, and not only HIV, but Hep C. This is another co-occurring chronic medical condition that we'll often see with intravenous drug use. We see so much pushback, though, against needle exchanges. In Florida, they've cleared it. They're going to have a needle exchange, safe syringe access, and then also there's a lot of different terminology, but I think the standard terminology that's been accepted by our field is OPS, overdose prevention site, but you'll hear people call them comprehensive user engagement sites. So these are supervised injection facilities. So while we've seen a lot of progress, Colorado, Denver just recently passed one. Denver's all over the place. It's okay to have shrooms in Denver. They're quite a progressive city compared to the rest of the nation. But we see this pushback. And in Philadelphia, one of the states, Pennsylvania, which has one of the higher rates of opioid mortality, they're trying to put together an OPS, an overdose prevention site. And they are getting so much pushback from the higher-ups at the state. The Department of Justice has stalled the movement towards opening the OPS, and basically has conveyed the sentiment this is never going to happen in Pennsylvania. So it's very sad because in the meantime, we continue to have people in the Kensington area of Philadelphia just dying left and right because they can't have access to clean needles. And it definitely underscores the current administration's attitude that no one should ever inject anything ever, period. So just say no. So that leads us a little bit to the types of stigma that people face. I got to catch up. I have such a vision impairment. I was not prepared for this monitor to be so nice and big, so I had to print out my notes, which I always have to be prepared when you're as blind as I am. So there are two main factors that influence stigma. There's cause and there's controllability. We see stigma decrease when a person believes that it's not the other person's fault. We see stigma decrease when you and I believe that so-and-so can't help it. There is an aspect of volition or choice or control or however you want to construe that, extrinsic, intrinsic capabilities that people may have. There's something about that mediates stigma and whether we believe somebody is worthy of help and dignity. So stigma from within, we see a lot of this with people with substance use disorder, and it's often been fortified early in childhood with some sort of trauma, abuse or neglect, but we see a lot of trauma as a clinician in the field. Every time I did an assessment, there was always some either very explicit trauma story or hints of trauma that this person just is too afraid to reveal in almost every single assessment I ever did, and I've done thousands of them. So there's stigma from within. They may blame themselves or feel hopeless. They face stigma within the recovery community. There's a pecking order in the recovery community. It's often joked about that, like, people at NA make fun of the people from AA, like AA, we're all stodgy and we wear mom jeans if we're ladies, and we have, perms and cardigans. And then the typical stigmatic theme for the people at NA is they're all tatted out and like pants dragging down to here and sucking on a menthol cigarette and slamming Red Bull and cussing like sailors. And the fact of the matter is that's not typical of any one group or the other. And then between that, within that sort of dominated ranking of these two 12-step fellowships, then you have the people who have to use medications, right? So pharmacotherapy or medications for opioid use disorder, whether it's methadone, buprenorphine, or naltrexone, those people are not so much naltrexone, but with methadone and buprenorphine, you see those people receive a lot of stigma from their own recovery community. And this is why we have such a crisis with opioids, because for so long MAT has been downplayed and often vanquished by professionals in the community because it was seen as a crutch. So that just kind of goes to show how you can have stigma within the very community that you would think you could turn to. Sometimes people with substance use disorder face stigma from the very practitioners that they are seeking help from. And I say this with knowledge that I know a lot of nurses and EMS. I know doctors. I know people, sheriff's office, who will tell you we see the same people over and over and over again. And so that does start to wear you down because you're called to help people in public service and as a first responder. And if you see the same people over and over and over again, it may lead you to believe that what you're doing isn't working or the system that you've joined to be a part of is not working. It's that second part. The system that we have joined to be a part of is not working to address people with substance use disorder. Oftentimes, some practitioners will have an inaccurate belief that treatment isn't effective and that people don't get any better. I took an Uber ride last night with a paramedic who told me, once he found out what I did for a living, that most of the opioid users he addressed out in when he was in the ambulance didn't want help and they were incurable and they were just hopeless. And it was a short Uber ride, and that's good, probably, because I really wanted to give this guy a mini degree of education in what opioid use disorder is about. And that's a whole other thing. I see a hand up. Yes. Yes. Mm-hmm. Yes. 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 Hmm? Yep. Yes. Yeah.
So I listening to you, I went backward
Yeah.
for the last three, but it was just like it was a process.
Thank you.
How society, but you're taught or not taught.
And that's what I do in every contract that I have and at the Opioid Response Network, which I'll give you a little bit more information about later, is basically helping to develop a better infrastructure for medication-assisted recovery or pharmacotherapy in recovery or however we're going to frame it. That is not just about, yes, harm reduction. Dead people do not recover. And we would not tell somebody who has, bless you, diabetes type 2, that they did this to themselves with all that Coca-Cola, and that they really need to go get some counseling for their eating disorders before they're allowed to have insulin. It's just incredible to me that we have these separations. But then it's even more compounded when you look at HIV-related stigma, because those who have HIV-related stigma, well, I just love that I got to dig into some research and found out these different types of stigma: internalized, enacted, and anticipated. And internalized would be just negative feeling, self-stigma. I think we've heard some people call it before, where we direct that shame towards ourselves. But enacted, these are the actual experiences of discrimination and prejudice that people are exposed to. And then this is what I think is really interesting: anticipated stigma, the expectation of discrimination, stereotyping, or prejudice. And I think that Amelia, when she talked a little bit about the differences between what we see with whites and blacks with regard to who's buying and who's actually using, and then we also see that translate to the treatment world. We don't see as many people of color coming in as we do Caucasians. And that could be parity. It could be obviously health disparity. But it hit me when Amelia was talking that there could be anticipated stigma that people of color are experiencing, and that also compound their desire to reach out for help. So where does this all make a difference? This last bullet point, underutilization of HIV-related medical care. We got free services out there, but people are still afraid to go get them. And because they're worried. I know of some of the recovery support service providers in Houston have worked hard to focus on moms on methadone. And one of our coaches took a mom into a local methadone clinic. I'm not going to say what clinic it was in Houston. And this doctor, this physician, said to this very pregnant mom, "There's not much hope for women like you." And so that is so defeating, and it really, really does not do much to help people feel hope and positivity. This is an interesting study. Participants who had already internalized HIV stigma, they experienced some greater depressive symptoms if they also internalized substance use stigma. I mean, that makes sense, right? You're compounding the problem. And then in a study focusing on HIV positive youth, stigma was the only psychosocial variable that was associated with substance use. So you kind of see it coming one way and you kind of see it coming the other. And that speaks to a little bit of a validity construct with regard to the impacts of stigma. It obviously, you know, SAMHSA doesn't even like us to say stigma. SAMHSA wants us to just, the Substance Abuse Mental Health Services Administration, they just want us to call it discrimination and prejudice. They're like, we really just want to do away with the word stigma. But I think people have a hard time hearing words like discrimination and prejudice because it's a very polarized landscape socially right now. And I don't think you can just run at an audience of mixed diversity talking about prejudice and discrimination, although I would love to. So we talk about stigma. It's kind of like a little, we're just kind of getting, motivational enhancement. We're just kind of getting our toe in the door talking about stigma, and then we can talk about prejudice, discrimination, and health disparity and how they're actual real things. But we see a lot of issues that have been, you can look at, in fact, there's a citation up there. We see that these things have been recorded. These are metrics that are recorded as impacts of stigma. I'm trying to be careful of my time. So I want to imagine this scenario. If you went to the hospital, we kind of alluded to this a second ago with type 2 diabetes and insulin as sort of a metaphor or a parallel. But if you go to the hospital and you have chest pain and you are having a heart attack and the doctors and nurses tell you it's your fault because you drink too much Coke and you eat too many Doritos and you can't stay away from Whataburger, and they tell you it's your fault and you don't exercise or smoke enough, and they refuse to give you treatment because you have done this to yourself with your eating choices and your sedentary lifestyle. And instead of immediate care, they give you a list of phone numbers for cardiologists and send you on your way. What if instead of being given life-saving medication, you were told you could only get that medication if you also agreed to go to counseling? Or worse, what if you were kicked out for having a symptom of your disease? This all sounds outrageous, but yet this is what people with addiction face every single day in the health system, whether it's a community organization or a licensed clinical organization. This is what the people who struggle with substance use disorder and addiction, they're blamed for their disease, denied treatment, told to find care themselves, denied life-saving medication. So like buprenorphine, for instance, which is also known as Suboxone or Subzolve, a Sublocade, there's a litany of names, is often denied to people with opioid use disorder unless they do counseling. I read a recent VA recommendation for opioid use disorder. Did I go too far? Where the VA said, this was like a 2012 document, and the VA said, if they've had any overdoses, you need to discontinue their MAT. If they have asked you for higher doses, you need to discontinue their MAT. If they are drug seeking, you need to discontinue their MAT. If all those things are happening, this person is not at a therapeutic dose. And the most impactful and fatal thing we can do is discontinue MAT. So people get kicked out of treatment for substance use. People may be compliant with their MAT program, but still may be smoking some weed. Well, weed's not legal in Texas, so that's problematic, right? But they're considered non-compliant. Whereas really, if you have a clinician who's devoted to addressing addiction, they're going to wrap around that marijuana use and say, okay, what's going on here? So we're working on this. What can we do with harm reduction with that? And do we need to get some recovery supports involved in your life? Gosh, I really need to catch up. People who use drugs. Have you guys ever heard that acronym? PWUD? Mostly, like we hear it in social work a lot. This is a quote that was pulled with regard to somebody's experience. And what I want you to know is the P in PWUD, people who use drugs, also stands for patient. Patients who use drugs. They're still patients, and they're still people. So we know we have stigma, we know we have discrimination, and we know we have prejudice, and it often comes from biases, and it comes from beliefs, and it comes from generational mores and cultural cues, and it's just not easy to break down, right? It's very nuanced. I like to say nebulous. It's very nebulous. I was corrected. Somebody was like, that's an inappropriate hyperbolic use of the word nebulous. And I was like, forget you. I'm going to use nebulous. So where can we start? Just looking at our language, right? Just starting to examine the way we interact with others with our language. If you want to take a look at this slide right here, and I'm going to catch up in my notes. This is what always happens. I make notes, and then I go off track. Now, we have found that the American Society for Addiction Medicine has really helped advance some of the work that is happening with physicians to help them really kind of understand more about the disease of addiction, how the neuropsychology, the biopsychology, and kind of shift the paradigm from a pathological framework. Thank goodness for their levels of care, and I'm hoping to see every single person who deals with somebody who has a substance use disorder or a problematic substance use start looking at the ASAM levels of care as far as being able to help the person that's standing in front of them, because often we're just like, okay, you got a little problem. We just go and put you through detox and send you through 28-day rehab treatment, and you're going to be okay. And that is not actually okay. And really, ASAM recommends that you start with the lowest level of care first before we route people through more intensive levels of care. But ASAM's done a lot of work around language as well. Words have power. This is a great quote. If you're interested at all in the power and hope of recovery as opposed to the pathological stance of addiction, look up William White. He's done a lot of great research and has written just profoundly. If you want to care for something, you call it a flower. If you want to kill something, you call it a weed. Stop talking dirty. Get rid of the word abuse. John Kelly out of Harvard, he runs this great agency called the Recovery Research Institute. Check him out. He's actually done controlled research with the word abuse. You'll see us say substance use disorder, substance misuse, and dependence. But the word abuse has roots that are deeply intertwined with connotations of predators and domestic violence and murderers and rapists. And the particular study that John Kelly did was he took two scenarios and presented them to highly trained clinicians, and the only difference between the case presentation was the word abuse in one scenario had been replaced with person with substance use disorder. And in the case of the abuse scenario, the abuser scenario, the clinicians recommended more punitive methods for treatment than in the scenario where the person was described as a person with substance use disorder. As a person in recovery, I don't want you to identify me as an addict. I'm not an addict. I am so much more than that. I'm not just a lush or an alcoholic. I'm so much more than that. I'm a professional. I'm a subject matter expert. I am a mom. I am a daughter. And I used to have this problem. And I don't anymore. Thank God. We want to avoid words like dirty and clean, especially if we've got toxicology, anything like a drug screen. We want to talk about that drug screen as either being positive or negative. It's that simple. That's clinical language. If we're clinicians in a room, we want to use clinical language. We want to consider talking about, and I come from an opioid response network, so there's going to be MAT stuff in almost everything I present to you guys. I'm sorry, but it's just part of what I do to help diffuse the stigma for people who are on MAT. We talk about medication-assisted recovery and pharmacotherapy a lot, but there's another term that just as of the first week of May has been promoted and proposed by the Academies of Science and Engineering and Medicine. And you can pull this PDF up online at their website, but they're now proposing MBT, medication-based treatment. So the lexicon is always changing because it's a rapidly developing landscape around SUD and particularly OUD, opioid use disorder. Well, we need to stop saying detox. Medically supervised withdrawal. Let's use our clinical vocabulary. Ways to reduce stigma, education, literacy campaigns. Amelia talked about peer contact. That is so important. And I do believe, Amelia, I hate to correct you, but I think it was $3.4 million in the first 2 years that we saved the state of Texas with our statewide substance abuse block grant funding, and I had to use the word abuse in that title, of peer recovery support services with 22 providers. It was over $3.4 million. That peer-to-peer contact is legit. Don't downplay it. If you guys can get some recovery support services that involve peers, involved with whomever you serve, it'll make a world of difference. Advocacy, if you like going to the Capitol and rallying and getting all crazy and using your clinical language with a bunch of legislators who don't know much about clinical things, but pass laws continually that affect clinical things, go talk to them. Legislative policy change is a really important way. I forgot to mention a language audit. Going through I totally went off track with my notes. I knew I was going to do that. So I'm just going to give up now with the notes. Go through your documents if you really care about the language you're using. Do a search and replace. Search abuse, replace it with people who use, you can replace it with use or misuse. Abuser as a noun, replace that with person who uses substances. This would be your internal documents, your marketing collateral, your informed consent, your policies and procedures. That's just the most basic way to start. But then also think about this person that's in front of you, even if it's a frequent flyer that you've seen 46 times in the emergency room. And just think about what it is that has plagued them so tremendously that they are in front of you again for the 43rd time in the emergency room, desperate. And try to make that connection. So we can all play a role in this. What I'm hoping to do is see us transform the system. And if you want to know anything about that, you can see me after this. And thank you so much for your time. I really appreciate you all today.